Welcome to another episode of Oncology Spotlight. For today's episode, we're exploring the world of hematology.
Right, thanks very much for joining us today, Hisam. To kick things off, can you give us a brief introduction of yourself and your background?
Thank you, Kevin. My name is Hisam. I'm a locum hematology consultant currently in the West Midlands, based in the Birmingham area. My primary interest is medical education centered around hematology training. And my day-to-day work involves basically dealing with acute hemato-oncology, which is a lot about leukemias, lymphomas, and a bit of general hematology coupled with some red cell stuff, because I work in the regional red cell center in Birmingham, which is part of the bigger picture of giving hemoglobinopathy treatment within the United Kingdom through different centers in different big places. And what I like doing are hematology initial diagnostics. So anyone who comes in is a bit of a puzzle is a bit exciting. So it's interesting to summarize. I do white cell as for my bread and butter, but I teach red cell to hematology trainees. So, and do a little bit of that. And I've basically trained up north for my hematology training and finished all my prerequisites and exams in Birmingham.
Very good. And Hasim, what inspired you to pursue a career in medicine?
Well, that's an interesting question. I still remember my father, who is a professor of ENT, telling me that don't become a doctor. I'll send you to Switzerland and you can do hotel management. So every time someone asks me this question, that particular moment in my life kind of rings, with a certain bit of, echo. But frankly speaking, I think I've come from a family of doctors.
Okay.
Being from a certain social aspect, because I was born in Pakistan, you kind of live medicine, look at your parents, look at your father's friends, you kind of roam in the same circle. So you're kind of partially expected to kind of follow the line. But I think my father did give me the option not to. And I think that was probably the catalyst that, I was like, no, I need to be a doctor.
Okay.
So, but I always liked helping out people. I'll be honest, at that point in my life, like many other people, I wasn't really sure what I really wanted to do. So maybe I think I was helped along a little bit in my decision making, if I really have to be honest.
Okay. What was the reason why he offered you the other option, or was there?
I think he was, because he had worked in the NHS, he trained in the NHS himself. I think he kind of foresaw what we are seeing right now.
Okay.
As in that this is the golden age of medicine is finishing. Stress levels are going to become high. There's going to be a lot more that's expected of you. If you go to the United Kingdom, there are going to be restraints. The system obviously works around certain principles. It may be better for a happy-go-lucky guy like you to just go to Switzerland and, just study hotel management. But I think that's what his thinking was at the time.
And why hematology?
That's a very good question. If you look at my CV, I was a medical oncology specialist registrar. So I did sarcoma in breast as an LAT, which is locum appointment for training, which is like a fixed year training appointment in medical oncology. And when I went for my specialist interview for a 4-year substantive training number in medical oncology, I think those were the days when, not now, when people could say stuff, throw your file across the table and say that you're not good enough and you're not going to be a good medical oncologist. So I still remember in my interview, no names will be taken, but there was this bigwig professor from the Royal Marsden. He looked at my CV and he was like, nah, you're not going to get it. And I think at that point, there were, I think just to the credit of the overall system at the time, when I applied into a substantive number, there were very few numbers in the United Kingdom going about. So I think the competition was intensely high. And I think the bar was very high as well. And I think I may have caught Professor X at a bad time. I think I was the last person to be interviewed. And I think he'd probably gone through a lot of other people. And I just happened to be addressed in a certain way, which is fine. Because I remember walking out and it was in Bristol. I remember going back from Bristol to London at the time, telling my wife, I'm like, I don't want to do this. I think I'm going to do something else. Little did I know that I'd also been shortlisted for hematology. And hematology was something, because I was doing high dose chemotherapy in medical oncology, like testicular cancer and all the rest of it. I had applied into hematology as a little bit of a backup. I have to be completely honest. And then when I got interviewed, I wasn't expecting much. It was a decent enough interview. No one did anything outrageous, quote unquote. And I walked out thinking, I'm probably not going to get it, because I think I just gave very simple answers. And lo and behold, they offered me a 5-year training number. And that's how this whole journey started.
Fantastic. And can you tell us about Bread and Butter Hematology?
Yes. So I think a lot of it has come from being a bit bored in COVID. That's point number one. Point number two was, I think it goes back, if I have to kind of think about the real ethos of why I made the channel. Number one, I'm just a nobody. I'm just a hematology, a locum hematology consultant. I don't run courses. I'm not a UCL professor. The courses that I've attended from other people from my FRC path, I'm not that kind of level. So I think Twitter was just a safe space. I think I was looking for something on the lines of something fun, something to make people feel at ease when they're learning. I think a lot of it comes from when I was a trainee. I had to go through a certain amount of difficulty accessing good quality educational stuff. There's a lot of service requirements, I'm sure you can understand. So you have to keep studying in your own time. So I think a lot of it was borne out by my own experiences and training, which I always reaffirm to myself that whenever I become a consultant, I would never have my trainees go through the same. And I think when I did the Twitter thing, I wasn't expecting it to snowball to what it is right now. I was just thinking, maybe if I get to 100, that'll be a pretty big achievement. And it's steadily, slowly, consistently keeps growing, even to my amazement, even now. And it's now become a voice of quality of content for learning as far as UK-based hematology is concerned. So it's a moment of pride. I would say it's nice. It's surprising in a nice way to see how much it's grown to. And it just keeps growing. And I keep getting messages from people that they find the content to improve their everyday hematological acumen very uplifting and pretty positive. And I think that's the affirmation that I didn't think I would receive, but I think I'm getting it. And I kind of realize that I may have started this out as a bit of fun and probably not expecting it to grow to what it is, but it is what it is now. And it's pretty nice, and it's quite satisfying.
Yeah. And at last count, it's 3,262 followers. Is that right?
3262 or 3261 or something like that.
And climbing.
Yeah. And climbing, yeah. And you mentioned the messages. Do you find the majority of the people engaging with you are from the UK, or are they global?
No, it's an international audience. So I do get messages from UK trainees, because I think if you gentlemen know, there's something called as Twitter Spaces. So I've started doing that a little bit as well, trying to address. I did a couple in which a lot of people came, to my surprise even. And we were just talking about general training issues, and they would put their things on. They would say, how would you handle this? And how would you handle that? So it was just a little bit of advice. And then the next thing was, let's discuss some interesting cases. You bring your cases, I bring my cases. Let's just learn from each other. That was a pretty big hit. And then there was a teaching session that I did for basically questions that I teach the SBRs themselves. Because of MS Teams and everything, it's very easy to Zoom content. You can give them a link, they come, and they can engage. So it was basically free teaching, and I kind of enjoy it a little bit as well. I'll be honest. It's become like a guilty pleasure of mine, and the feedback that I get from it is that you are naturally suited to do all of this. You're innovative. You're using technological tools and everything. So it's very nice. I'll be honest with you.
Excellent. Yeah, and you have a Substack channel as well. Is that
So
right?
the Substack came about from what I would call is Twitter word limit is the word I would use, because I think when I started posting questions, there was a hunger for answers and a detailed answers on everything, and I couldn't really do that on Twitter. I had to make like multiple tweets, and then I realized that people just don't have time to look at all of that in that order. They just want something punchy in one order, 1 or 2 pages, and that's it. So I think Substack came as an idea within an idea, in terms of me trying to explain the answer to the question. And then when I was thinking about Substack, I was like, I can't make it like a book. I can't make it too formal. It has to be something that represents me as a person on the shop floor thinking. So if you look at my Substacks, it's very informal. It's written from a point of view of all the things that I've learned and all the knowledge that I can distill into salient features and how to think about disease, but in a very unconventional manner. And that has attracted a lot of attention as well, because I've gotten a lot of messages from people who say that this is so easy to read. It's almost like I am doing this or they are doing this in real time, and it's easy for them to understand. And most importantly, it sticks. So I've had a lot of messages from people to say, how you write, it's just easy to relate to because I think like that. It's almost like you're doing things in real time rather than a bookish approach in which you just write paragraphs after paragraph. So I think that was just my own take on it, I'll be honest. And it has resonated with people.
Very good.
Brilliant.
And what are the future plans for Bread and Butter Hematology?
That's a good question. A friend of mine was asking me the other day as well, and I really don't know. And the thing is, because I wasn't expecting it to be what it is now. So every time I keep looking, I'm like, what is something else that I can do? Well, the only thing that I think that I can do is keep posting good content. It just keeps the numbers coming in. It keeps me engaged as well. It keeps my kind of hand in kind of content creation and all the rest of it. So I like that on a personal level. Other than that, I will never monetize Twitter because that is not the ethos that I started off with. I had some colleagues of mine who said, oh, you now must monetize. This is the time. And I go back to the initial thought or thoughts of when I set this whole thing up. And I was like, it's designed to be informal. It's designed to be a safe space for learning. And I will never change that. And I will never monetize it. So perhaps I might come up with something else, maybe developing some courses or developing a website, which may be possibly more informative on a Q&A level. I have been approached by some colleagues of mine to do it. Again, it comes down to time. As you know, the NHS is quite reasonably pressured at the moment. My day-to-day job is, I wouldn't use the word consumptive, but I keep myself reasonably busy, and this thing is a little bit on top. So I think I'm just going to do what I can manage for now, and perhaps see what other opportunities come my way or anything else that I can do. But whatever I do, it'll always be in the space of medical education, trying to make things easier, trying to make content easier. Because for me, I think about myself when I stepped into the shoes of a junior trainee in hematology. It can be a very daunting world. You can come across people, quote unquote, who expect a lot from you right from the word go. They expect you to know hematology A to Z, or they expect you to do a hematology job. Some can be more forgiving than others. That's just a general thing. It happens everywhere. That's fine. And I kind of put myself in my own shoes in those first 6 to 7 months when I kind of felt more out of my depth and trying to learn things, but learning at a very accelerated pace, because that's how the system wants you to be. The system wants you to do things in a certain way, and it will not accept any deviance from it. So I think the channel gives people to learn in a safe environment, and I interact with them and I just kind of make them feel more at ease. And that generates a certain amount of comfort of users when they engage with the Q&A and when I engage back with them. So I think it's a safe space. They can make their mistakes. I try to help them out by putting comments onto people, especially the ones that I know who've messaged me who are SBRs in training. And I say, listen, why don't you think about this? Why don't you think about that? You need to be more punchy, more insightful. You're going to be taking FRC Path Part 2, et cetera, et cetera. So I try to help them along as best as I can. So I think it's a hybrid approach, but mostly based around comfort, ease, having a safe space for learning, and not feeling that if they give me a wrong answer, or if they give the wrong answer, they're going to be criticized in any way, if that makes sense.
Yeah.
So I think that's very important.
Okay, great. And taking a step back in hematology in general, what are you excited about in terms of the developments forthcoming in the next decade?
Yes, that's a very good one. So, we are living in the age of molecular medicine, proper advanced molecular medicine. I mean, it started way back when with Glyvec, or as people all generically called imatinib, which kind of set the scene in CML and gastrointestinal stromal tumors and all the rest of it. We are now, I'm excited with a lot of things. You have monoclonal antibodies coming in to diffuse large B-cell lymphoma. You have advanced JAK2 inhibitors coming into very difficult to treat conditions like myeloproliferative neoplasms. And you're getting high quality, non-bleeding potential anticoagulants, because one of the things that anticoagulants have always been, anticoagulants to me has always been a bit of a double-edged sword. Yes, it benefits, but there's always risks you take on board. And, and AML treatments are now coming up. I think acute myeloid leukemia, has been stagnant for quite a few years. And suddenly in the last 6, 7, 8 years, there's been quite a few drugs which have come into acute myeloid leukemia, and a few more are coming in. It's all exciting. I think the problem, I wouldn't use the word problem. I think the thing in the UK is access. Compared to our colleagues across the pond, and the FDA is reasonably more generous in terms of authorizing newer treatments quickly. I think NICE tends to maybe slightly is a slow adopter, is the word I would use. Not to say that it doesn't eventually come, but considering that our colleagues in the States have a different healthcare modeling system when it comes to funding compared to the United Kingdom, I don't think what the UK does is bad. You can maybe criticize it for being a little slow, but that's just the way the system is, because they have to be accountable for a whole system that is funded through government coffers. So I would say that uptake possibly is a little slow, but not the end of the world. You do get access to drugs. I think COVID, although it's been a catastrophe and it's been bad all across the world, from a hematology point of view, I think it's pushed a lot of medications that were kind of third, fourth line into the frontline category. Venetoclax and azacitidine is a classic example of myeloid early on in COVID, because azacitidine and venetoclax was not really frontline for people who were not considered very suitable for high-risk treatments. And I think because of COVID and the isolation that entailed as a result of the early part of COVID, and for people not to have that many side effects but still get their AML treatment, venetoclax and azacitidine was pushed forward as part of the COVID interim guidance. And I think it's done wonders. I have people who wouldn't be the fittest for high-dose chemotherapy, and they have gone into remission with venetoclax azacitidine. So there are clear benefits from all of these approaches. And I think British medicine and training. So to me, training and medical training is more important. And I think it's dragged us out of this complacency that everything has to be face-to-face. Everything has to be a book. Everything has to be a course, into the online space of Zoom, MS Teams, that you can learn when you're at home. I mean, it's very interesting to note that the FRC Path exam, which I took, which is face to face. Part one is you go to a place, they give you a sheet, classic, old school, multiple choice questions, you write essays and all the rest of it. Is now you can do the exam online on your computer in your house. So I think I think there's been a lot of positives that have come out over the last quite a few years, but again, it's put a lot of pressure on the system as well. So I think it depends on how you look at it, but I think the outlook going into the future, as far as all of this is concerned, and new ways of learning, is definitely on the up, because traditional books are on the out. I'd hardly see any trainee carrying a big book now. It's all about PDFs. It's all about bite-size pieces of info that you can get on the internet. You see 3 pictures that someone puts up, you ask them, what do you think this is? And then they get a reply to say, yes, you're right. It's very affirmative and very educational in a real-time fashion, if that makes sense. And I think that's the best way of learning. I think learning is changing completely. Gone are the days when you had to sit down, open a book, learn pathophysiology. You can see videos on YouTube. It's a whole different ballgame now.
What about CAR-Ts and all of these new treatments? Do you
Yes,
see?
I have colleagues, more intelligent, more cerebral colleagues that do CAR-Ts. I just refer people for CAR-Ts. I have a couple of my colleagues who are basically my mentors in the region who do CAR-Ts. It's really a niche science. I think for diseases like relapse refractory bad lymphomas that are not responding to conventional therapies, and you have young people at the end of it who need some sort of salvation, I think CAR-Ts and the success that CAR-T is having is actually a life-changing experience for some. Now, having said that, in some diseases, CAR-Ts probably are not the smoking gun that they were touted to be, but at least it gives someone who's, let's say, a bit young, who's unfortunately at the end of a relapsed refractory scenario with no conventional chemotherapeutic hope in sight, it gives them one more lifeline. Now, what the outcome of that is depends on obviously their individual characteristics, their genetic profile, and all the rest of it. But I think it's a reasonable lifeline. It's a very good lifeline for someone who may not have conventional hope. Let's say if you drew the clock back 10 years ago.
Okay. Excellent.
And just moving on, just in terms, you mentioned the patients and just coming out of just in COVID, coming out of COVID, and where we are now. How do you approach providing patient-centered care?
I think it's 2 things. One is holistic, and the other one is pathophysiological. I've become more attuned to looking at my audience, listening to my audience, because the pathophysiology and everything is available through your biopsy reports and the genetics and all the rest of it. It's all about how you deal with your patient audience. So you have to listen. Some people are generally more accepting. Most people need need help. So you have to you can't be pathophysiological all the time. You can't just be going completely in medical doctor mode when it comes to face-to-face consults or even online consults. You have to listen to what they're saying, what affects their lives. There are people who will take time out. The system does not help them because they don't earn that much. So you have to be pretty much aware of all these other things rather than just be a simple prescriber of chemotherapy and off you go. It's not as simple as that for me, because I have been a patient in the NHS. And so I understand how it is to be across the other side. And if you don't listen, if you don't see where those people are coming from. Yes, you might give them treatment, but how is it going to affect their job? I mean, a simple example is I had a patient who was a guitar player in a band, and that was his livelihood. And then you have to be very careful about how you dose their treatments, because if they get any tingling in their hands and they're unable to do their job, it affects how they work. So you have to take in a lot of things when you are talking to people. And you have to keep the holistic model at the forefront. The pathophysiology you have to address anyway. There's nothing you can do. You can't just talk to, you can't just wish away someone's lymphoma. It has to be treated. But how the treatment affects the patient in their journey, I think it's very important for you to be a part of it. And that's why, I'm very grateful that I have clinical nurse specialists. It's just never one person. It's always a team effort. So you have clinical nurse specialists, you have psychologists, you have cancer accident helplines, you have all these other conduits that people feel safe about, Macmillan and all the rest of it. So I think it's a journey which is underpinned by a lot of things. It's not just always one person. It never is, and it never should be. It's always a team effort. And I think the more people in your team you have, the more valuable assets you have, the more the patient benefits.
I suppose it's across the board. There's multidisciplinary people involved across the spectrum with patients. Like with the NHS, like the pressures now that are in the NHS, is it becoming a lot more strained, or what's your
Yes, it
thoughts on
is.
that?
Yes. I think capacity is becoming an issue. I think clinician to patient ratio is an issue.
Yeah.
Not to say that we are not trying our best. I think me and my
Yep.
colleagues, we try our best. Diagnostics have become good. Pickup rates have become higher. Then you have government targets. But then at the end of all this, you have deployment capability. If let's say in a hypothetical cancer center, you need 10 hematologists to kind of man the floor properly, and you're running the shop floor with 6 and you have a lack of 4, you are doing extra work. You are pressured. And you try to do your best. There's only so much you can do safely. And I have to keep emphasizing the word safely, because at the end of the day, that is the most important thing. Yes, we want to get all our patients to whatever treatment modality they need quickly. But I feel these days, the NHS is strained on, as you can tell, without going into too many details. Morale is at an all-time low. And it's difficult these days, but we try to do the best job that we can. And in my hospital, we really try our best. I mean, compared to my colleagues, I'm the youngest consultant in my whole group. So I'm a bit more millennial. So I'm very easy with MS Teams. If I can't get anyone into my clinic, I'll send them a link on Teams and, let's have a little chat. Let's follow up. I'm a strong believer in very incremental bits of information goes a very long way in patient satisfaction. Because if you just leave discussions to a clinic appointment, then a lot of it piles up. But if you keep addressing things in little small pockets as you go along, you will find that your patients are generally more accepting of their situation, are more in the know. They feel like they are part of the process. And I think it is very important to make them feel that they are part of the process. Because I've seen some, let's say, quote unquote, very interesting consultation models when I was a registrar, and I never want to emulate those. With all due respect, I think it's much better to engage with people, spend that extra few minutes, extra 5-6 minutes with a new patient, explaining to them what the objectives of treatment are, what is the actual expectation of treatment, where can you get to, what's the ideal state, what's the real world state. You have to be reasonably honest, because I strongly believe, patients are human beings. They understand that you can't deliver everything, but as long as they know you are trying your best, and you have let's say a plan A, B, and C to counter whatever lies up ahead, I think that's all patients want. Patients get angry in the NHS, and a lot of complaints happen mostly because of lack of communication. Suddenly,
Yeah.
you talk to someone and you don't mention a scan, and then patient gets a scan letter in the post. You obviously, you can freak people out, understandably, to say, what has he had not told me? What am I looking at? So I think I try to spend that extra little bit of time to kind of explain. And I do tell them, I said, if you get a scan result, a scan appointment, that's only because I want to do this, this, and this. Be honest with your patients. They're accepting of it. And a lot of people, to my personal experience, actually engage with it and go with it. But it's the lack of information that can equally make people tense. And that can start to really strain a patient-doctor relationship if not handled properly. So I always think incremental changes, little bits of information, even a quick phone call to say, hi, Mr. X, how are you? It's just me. Listen, I'm just ordering a scan, nothing to worry about. This is what we're doing, et cetera, keeps everything moving along in a nice streamlined fashion.
And thinking globally, what do you see are the biggest challenges facing hematologists at the moment? I know we talked a little bit about the NHS, but from a global perspective.
I think it depends on which healthcare system you're in and how well funded or endowed that particular healthcare system is, and what access to medications and treatments through which economic insurance pathways, etc., you have. I think challenges globally are to kind of get a standardization of treatment of diseases. Everyone's entitled to do a slight deviation of a bit of this and a bit of that. And I think that kind of stems from access of drugs in different places. I mean, to go back to my own home country, it is still a challenge to treat very simple conditions because there is a lot of healthcare disparity. From a socioeconomic point of view, a lot of people live below the poverty line. Diseases don't look at how rich or how poor you are. They present in the same ways.
Yeah.
And it's about access to drugs, which can become an issue, and how my colleagues back home deal with these conditions. I mean, a simple example is back home, in some instances, if people can't afford TKI therapy because it's too expensive, the government programs tend to give them a stem cell transplant and CML, which is curative, but it's not how things are practiced in the West anymore because you get access to all the drugs. So the way my friends and some of my colleagues practice back home is based on the constraints of what they have to deal with. And a lot of it is, blood testing and molecular testing. I mean, I close my eyes and I request a JAK2 or a BCR-ABL or fancy molecular test this and a molecular test that, because it's all funded. I've become used to it. It's autopilot for me, but it's not the same thing when it comes to someone who has to pay out of these things from his own pocket, let alone treatment that may cost hundreds and thousands of dollars. So I think compared to the United Kingdom, possibly Germany, a lot of Western Europe and the United States, I think colleagues all over the world are, and that's what I get on my Twitter stream as well. When I put a question, or just say what would you do, I get very interesting replies, and those are based not from how you would do things in the United Kingdom, but how they do them locally and what works for them. So I think it's been a great eye opener in terms of, you get cocooned in your little world and you think this is how the world should be and this is optimally how hematology is run. But no, the world is a pretty big place and there are challenges. And I think my colleagues all over the world, they do a great job.
Very good. And finally, is there anything else you would like to share with our listeners regarding hematology, your work, or any upcoming projects you're excited about?
So I have partnered up with two of my other colleagues. One of them is a hemato-oncologist from India. He's got a very big following. And another colleague of mine who's a senior biomedical scientist in Guy's and St. Thomas's in London. We have collaboratively made a new group called Heme Bites, which is going to be teaching topics. So every disease, and we're going to do it on MS Teams. and we're going to be doing an interactive Q&A just to kind of, again, on the same model of making learning easy, making learning fun, making learning a safe environment. You can ask your questions, you can say whatever you need to say, and we'll hopefully help clarify and distill your statement so you can be better at what you do in your everyday work.
Very
So that is something I'm just a little busy. I have made the first presentation, but my colleagues are just busy because, it's just that time of year. Hopefully we might be able to roll out the first session in a few weeks' time. And just thinking about what else I can do to kind of make learning easier. And at the moment, it's Twitter, a little bit of Substack. It keeps my basics very grounded as well, because when I have to write something, you have to have good basics in mind, and you have to make basics easy to understand in a non-bookish way for someone to read in 3 minutes and understand exactly what you're trying to say. So I think it takes skill. It's a skill that I'm learning. It's a skill that I am developing. Every day is a school day, and I don't take anything for granted. And I just keep doing every day as if, I'm trying to do something new, something positive, and something that would be meaningful to someone else, which is the most important thing.
Fantastic.
Thank you very much, Hisam. Really appreciate your time. Thank you
very much. Thank you.
Thanks for your time.
Thank you. Thank you.